Welcome back, everyone. We're going to start a panel, and the topic of the panel is going to be the impact of the pandemic and changes in administration on the payers. And it's really an honor to introduce this session's moderator, Sajid Ahmed. Many of us in Southern California know Sajid through his work and also his participation at several HIMSS events. Sajid currently serves as the CEO of Wise Healthcare, and prior to that, he served as the CIIO at Martin Luther King Jr. Hospital. I would like to invite Sajid to take over and introduce our esteemed panelists. Thank you, Sajid.
Thank you, Sunny, and thank you to HIMSS for providing an opportunity for these amazing leaders that are going to step up here and talk soon and to kind of speak to their experience over the past year. Let me provide for everyone just a quick edit. I think the topic that we have, the impact of the pandemic and the current changes in administration in DC, I think we have an answer to that the group here is going to talk about, which is really inequity and access to care and all the things that we've experienced, that they've experienced, and how their organizations have managed. The panel that is in front of you really deserves a much longer introduction, but many of you that are on this conference should know them well. Let me just introduce them as John Baackes of LA Care Health Plan, CEO, Richard Sanchez, CEO of CalOptima, and Jarrod McNaughton, CEO of Inland Empire Health Plan. Earlier, if you caught on, you probably heard us talking a little bit. I was just adding up all their years of experience and from their bios, and it's a little over 108 years of healthcare experience, and not just all on the plan side. There's public health and there's hospital experience and also both public and private experience. So I think you're going to get some really exciting conversation, and that's what this is meant to be. A fireside chat amongst these veterans who will share what their organizations have encountered and managed over the past year, and hopefully what they see as the changes that need to occur in the future. Let me just say one last thing. All three of these CEOs represent public organizations that are not for profit. They're transparent. They serve underserved populations and communities in their local counties here in LA County, Riverside County, San Bernardino County, and Orange County. That represents a little over 5 million health plan members across the various payer sources, Medicare, Medi-Cal, Medi-Medis, and a few others. So it's very, very exciting to have them hear their thoughts. And I just want to read a quick definition and then ask John to kick it off for us. I want to read the definition of health equity on the CDC website. It says, health equity is achieved when every person has the opportunity to, quote, attain his or her full health potential, unquote, and no one is, quote, disadvantaged from achieving this potential because of social position or other socially determined circumstances. I look forward to hearing from John, Jarrod, and Richard. And John, thank you to all three of you, by the way, for making the time on this Friday morning. Would you mind kicking us off with your thoughts on it? And I really do want to impress on you that this is a conversation, like actor to actor, so CEO to CEO conversation. My role will be to just tap you at near the end of the panel to have you say a few last words. But go ahead, John. Thank you.
Well, thank you, Sajid, and it's a pleasure to be here with both Richard and Jarrod. We do talk to each other, compare notes on a regular basis. I think in the context of the title here for today's session and your opening remarks about equality, I think we all have commiserated how the pandemic has been for our members of our plans a really horrific experience, because we take care of people who are the most vulnerable. Almost all of them would have to say that they could not reach their potential for health equity under current circumstances. What we saw during COVID was that people of color and people in poverty bore the brunt of this disease. So when we talk about the idea that people are dying in the streets because of inequity, it's literally happening. And I think what most of us want to do is use this opportunity coming out of COVID to seriously address the inequities of our society and how they do impact someone's health. So for instance, in our health plans, and I'll use LA Care as an example, 44% of our members are Latino. They had 3 times the rate of infection, hospitalization, and death than our white members. And why is that? Well, 1/3 of the people who are on Medi-Cal work, which the public doesn't believe, but that's the truth. Now, many have full-time jobs, some have part-time jobs. When the pandemic hit and the recession, those people, 2 things happened to them. They were either immediately laid off because they worked in the service industry. They were the housekeeping staff, the bartenders, the valets, and kitchen staff, or they could not remotely work from home because the jobs that they had, also in the service sector, required they be there. They couldn't do it from their living room. And as a result, these people were exposed more. They couldn't take advantage of what people with more resources could do, which is safely work from home or go to their vacation place at Lake Tahoe or something and work from there. So what I think we felt, I felt during the pandemic that we were not able to do as much for our members as we could because they started out in an inequitable position. And I think what we should be focusing on is, all right, now what are we going to do so this doesn't happen again?
Yeah, absolutely. Let me get you guys warmed up. Jarrod and Richard, jump in if you like. I just want to mention, Richard, maybe you could follow John right here before Jarrod jumps in with your 36 years of experience, but also a lot of that on the public health side. Before becoming CEO of CalOptima, you led the public agency for health in Orange County.
Yes, I did, and that does inform a lot of my view of inequity in Orange County specifically. But maybe as the keynote speaker actually captured a lot of the points that I was going to hit on, because I think it's universal across the nation of what you see in terms of inequity. The pandemic, as John said, I don't want to repeat, but I will repeat this. John rightly pointed out that if there was anything good out of this pandemic, it did finally show very starkly the impact of inequity of health on the population at risk, our most vulnerable population, which Jarrod, John, and I are taking care of in our respective counties, and the deadly impact it had. In Orange County specifically, we are very much looking forward to the implementation of CalAIM, which is, I view as California's version of social determinants. And the previous speaker, the keynote speaker, touched on those issues because when we polled our population here in Orange County, they identified their top needs as food, housing, money to buy things, and transportation. And number 1 was money to buy things. Number 2 was food. So she also mentioned, kind of Maslow's hierarchy of needs. Are you going to get your shot, or are you going to try and put food on the table? So when we talk about the vaccine hesitancy, if you will, I'm not sure that's what we're seeing in this population. It's more the time, what it takes to get there. And everybody's touching on telehealth. Another point I just have to hit on in terms of the inequity we saw in terms of people gaining access to care during the pandemic when people didn't want to go in person to the doctor. If you don't have broad internet, if you don't have a computer, if you don't have an iPhone, or if your area doesn't have those the bandwidth to handle those things. These are the kinds of issues that were brought up. And we saw a significant increase in telehealth. We went from 100 quarter one to over 200,000 in quarter two. That was like the steepest increase I've ever seen in my life in terms of people switching over. But was that our population? We have almost 1 million. So that was some of our population, but not all of our population. So the IT needs, the looking at what our population needs to quickly access to something like that are things we need to look at. And I could go on and on, Sajid, but I know we have another speaker.
Well, I think you're providing a segue for Jarrod. Jarrod, I know you mentioned this as one of the key things that has been made aware in the Inland Empire. Can you speak to that a little bit more, the digital divide?
Well, you bet. It's great to be with you folks. I happen to be in Washington, D.C. today. And so I'm just so happy that I could be somewhere where I'm hopeful that folks here in the D.C. area will take note of to really help us move on some broadband access. In our particular health plan there at IEHP, we serve the largest geographic area of all of the public health plans with about 27,000 square miles, some very unique situations where folks that live in communities in the Inland Empire that literally have no provider coverage at all. And because of that, our transportation costs, for instance, pre-COVID, when we were moving people around throughout the IE to get the care that they needed, for just 1 year was well over $100 million. It's incredible how much money we were paying to move people around. And overnight, as Richard and John said, that of course transitioned quickly into the virtual care side. And if there was one good thing that came out of COVID, it was that both the state and federal government became very reactive in a good way to get virtual care and virtual visits moving quickly. From telephonic to virtual visits like all of us are doing today. But as Richard pointed out and John pointed out, the access to broadband, especially in our geographic area, is incredibly light. It's very, very tough for people to have access either to broadband internet access or to have a device that can actually connect in. And so this initiative that's underway right now to both virtual visits as part of the ability for our providers to serve our members is of utmost importance, both on the federal and state side. And in addition, making sure that folks have access via a mobile device or some type of a device to have that. Plus, some of the really great work that's happening on Bluetooth connected devices for blood pressure monitoring, glucose monitoring, and other things like that has to even escalate and happen more. And so our hope is that both the federal and state side will continue the push to keep that as part of the plans, to make sure that the reimbursement flow for that happens, to make sure that our providers have access in their own offices, because many of them did not also have even an EMR system to be able to connect in, like you would imagine. And so all of those things, I think, are the good things that did come out of COVID. But to both my colleagues' points, the incredible inequity was actually, I think, the spotlight was shown even brighter on those inequities. And I'm just thrilled with the work that Richard and John and our team at IHP is doing to try to help really fill the void on the digital divide with some unique advocacy work that's happening in Southern California. So I really appreciate that.
Awesome. Well, look, each of you got a chance to kind of get started here and get warmed up. I think to kind of push this along in the way that it needs to be for a fireside chat, I'm going to ask Jarrod and each of you in turn to ask the other or the other two a question about what their organization has been doing or plans to do, and really kind of instill this conversation. So Jarrod, you made some excellent points. And I know, as John Baackes mentioned, you guys talk all the time and connect with each other, especially during this past year, during the pandemic, and being adjacent to each other in the service that you guys provide in the counties. Is there anything that you would want to ask John or Richard or both of them, specifically, so that the audience that's listening in can get some insights? Is there any question you have for the other two?
Well, you know, it was interesting because our organizations share a lot, Sajid, as you might imagine. In fact, Richard and I, we just had our teams together. I think, Richard, it was just a week ago or so to actually share some best practices around innovation and to learn from one another on what we're doing with our plans and strategies in the future to how to best really meet the needs of the populations that we serve. And of course, John, being a neighbor as well of ours, we do a tremendous amount of work together. They're fantastic partners in Southern California. And I would love to learn from my colleagues while we're on the line, something unique in their organizations. And I'll just share with you a uniqueness that maybe they can piggyback off of. You know, when I arrived at IEHP about 3 years ago, my whole career prior to this was spent on the provider side, where I was the CEO most recently of an academic medical center back east called Kettering. And I had assumed that with the health plan side, you know, it's interesting when you come from the provider world, and Richard may have seen this from his past life in public health and other county agency work, and I'm sure John did from his past life on the East Coast. I would have assumed that some of the work that happened with EMR integration, for instance, was a little bit more down the road, especially within California. And I was quite frankly shocked when I was sitting across from our clinical analytical team, and they had shared with me, Jarrod, you're going to be amazed by this, but we have 433 different electronic medical record platforms in our market. And I just was blown away. In fact, I'm rarely shocked at that level, but I could not believe it was that many. And I'm curious if my colleagues are seeing that kind of level of just unique differences within their market among the primary care groups and the hospitalist groups, or if they're seeing more integration happening within their market. Because for us in the Inland Empire, it's a huge barrier to the things we're talking about with the digital divide, and also with, of course, access for virtual care visits and among other things.
Well, I can tell you that in LA County, it is as big a mess as you described in terms of the different number of platforms. And Jarrod, I do want to observe that you're in Washington, D.C., and I assume you're there to personally collect some relief funds for Inland Empire Health Plan and fly back with it in cash. Very good move on your part. We're very concerned about with the greater issue on the digital divide. So yes, having a lot of different platforms makes collecting data, particularly because the three plans have to report encounter data back to the state, and trying to collect it from all these different platforms is a nightmare. But I think it's the bigger issue is for the members, and we mentioned earlier the digital divide. So again, during the pandemic, while it's great that CMS has allowed telehealth to go on, we know that for many of our members, they may have a cell phone, but they don't have a smartphone. So they're limited in their ability to take full advantage of that. And of course, we hope that CMS extends their approval of this beyond the pandemic emergency. So one of the things we're doing at LA Care that since that was Ask Us Something that we're doing, you know, we have 8 community resource centers, and these are storefront locations in strip malls, but on the street that we have had for years, and we're building more. We'll have 6 more by the end of 2022. So the community resources are places that people can go for health education classes and so forth. But in a partnership with Blue Shield Promise, we've expanded, and what we're doing is putting telehealth connectivity in those resource centers. So if someone doesn't have it at home, they can come to our resource center that's closest to where they live, and they can get online and do a visit with their provider using the best technology that's available for them. We think that will save them from, if they can't participate electronically because they don't have the right equipment, coming to the resource center will be easier for them than actually going to the doctor's office, which we know for many of our members, transportation is a huge challenge. So we think those resource centers add value because they're more than a plastic card in somebody's wallet.
So if I could jump in here, going kind of back to what Jarrod was talking about, my experience with public health, unfortunately, was similar in that even within my own agency, where I had public health, behavioral health, and I had actually the care of the inmates at the jail as well as part of the duties that I had, all three using different platforms within my own agency. So I couldn't even talk to each other within my own agency. I will say the County of Orange did take an initiative recognizing that the link between health and other agencies, social services agency, our housing agency, and our criminal justice system, quite honestly, our sheriff's office and district attorney and public defender created what they call the Orange County Criminal Justice System Coalition. And one of the first efforts, and this is pre-pandemic, so the issue at the moment was homelessness. And so realizing that that population frequently touched base with all of those agencies, why aren't we talking to each other? Why aren't we talking to each other? Because we all have our own silos and we all have our own systems. So the effort was to create, at least within the county agencies, a way to talk to each other with data. We did pull in CalOptima at the time, the health plan, and we saw them as kind of the second wave of folding in addition to hospitals and others. It's scary. We scare people when we say, we want to see your data. And we scare people thinking, I have to buy, you're asking me to buy a whole new platform, a whole new system. No, that's what we did not say that. We were very clear. We're not asking you to change anything. We just want to be able to talk to each other because we need to, if we're going to look at a person through what we're now doing in California, which is as the whole person, every aspect of things that impact their health. And this goes back to social determinants because social determinants should include things like the criminal justice system, quite honestly. Not all of our population, but unfortunately a lot of our population. So we're starting that. It's at the beginning stages, but I will keep the group informed on what's going on and maybe successes and lessons learned.
So Richard, before you jump in, because you're the last one to speak in this round, think about a question you would want to ask the other two. But before you do that, I just want to highlight, I think for each of you, a certain, just recognition of one of the efforts you guys have each done in addressing inequity and in addressing, this access to care and interoperability. So one, John, it's amazing that you're expanding the resource centers. I know from when I was at LA Care back in the day, I think we were just opening our third, and this was, pre-Medicaid Medi-Cal expansion. To know that you guys are expanding, LA Care is expanding those resource centers and providing telehealth access, that's great. And I think, Richard, you're being polite as well. But Orange County, I think, is known for one of the best whole person care programs of the counties that participated throughout the state. In that effort of connecting your agencies together, I think whole person care, the initiative you and CalOptima support, you supported on the public side before joining CalOptima, I think has provided great value. And of course, Jarrod is being humble as well, I think, in addressing the over 400 different EHRs that exist within the two counties and the network of providers that IHP works with. IHP is launching a community-wide EHR initiative, a small pilot to start with, to help improve those, care delivery and quality metrics for those providers by providing a payer-sponsored EHR and in direct collaboration with local providers governing and driving that initiative. So you guys are all doing great work. So Richard, I've given you enough time here to think of a question for your colleagues or comments you want to make. So go for it.
I guess we're all recovering from the pandemic, if you will, hopefully getting ready to launch a big initiative that's going on in California. I mentioned it earlier, CalAIM, advancing innovation in the medical health space. Just wondering where, and know that I kind of already know the answer because we do talk to each other, but maybe for public consumption of what are we doing? And the first rollout, just so you know, it's rolling out in phases. It's over 6 years. And so just wondering what Jarrod and John think of the rollout. Is it going at pace? Are we behind? Should we be pushing for more changes quickly? Or do they think this change is big and difficult? Should we just go at the pace we're currently at?
Well, I'll jump in because I talk about this incessantly. We are being asked to do a lot. I would say what we have to accommodate for January 1st under CalAIM is as big or bigger than the implementation of the Affordable Care Act on January 1st, 2014, which gave us a lot more members, either through the expansion of Medicaid or our participation in Covered California, but the benefits were weren't messed with as much. The change in benefits brought by CalAIM is a big lift for many of us. My concerns, and haven't been shy in pushing back with the state, is that they are still making up the rules and the rates as they go along, and we can't turn on a dime to get these things done. So I'm concerned we're rushing a bit. Now, LA Care participated with Los Angeles County in whole person care and health home, so thank God we had that experience because it will make the transition easier. But it's a big lift, and we're happy that the state is doing it. I'm just concerned about our bandwidth and their bandwidth to get it all in place on time, but I'm confident about it. The other thing I want to mention is that because CalAIM is now allowing us to pay for a non-traditional health benefits like medically tailored meals or housing navigation services or recuperative care beds, these are things we were paying for prior to CalAIM. All of us, all three plans have paid for those things, and we've done it out of our unassigned reserves. So it's important that while we are not for profit, we still have to earn a profit to fund our reserves, and those reserves we've put to work by reinvesting them in the community in things that heretofore haven't been covered. So to me, that's the big thing coming out of CalAIM, is that we will begin to provide benefits that previously were not covered that we'd pay out of our pocket. Now, part of the reason we did it in the past was to collect some data to show that, if you do provide medically tailored meals for congestive heart failure patients, guess what? You cut down on ER visits and readmissions, and the cost of a meal for a year is cheaper than an emergency room visit. So we've been doing that for a long time. So it's finally, I would say the government's catching up with us, and we just want to make sure it doesn't come with too many entanglements in terms of red tape.
Yeah, and I would just add to that, I think John is spot on. I would just add that, our health plans, especially the public entity ones that we all represent, have a very, very unique role that we play in the communities that we serve. And in fact, I would argue that there's probably not another entity in our communities that can act as the glue to pull so many different partners together, community-based organizations, our county partners, of course, hospitals, providers together, as well as we can as health plans. And CalAIM is no question a huge lift. It's absolutely the right direction for the state to go. There's a lot of unknowns that are left, but I will say that we think it's the right thing to do for our members. We think that the integration that will take place with what Richard was talking about, even with the folks, everybody from the prison populations of when they get discharged from prison and released from prison, to make sure that there's a bridge that's already created there prior to them being released from prison into the Medi-Cal program, making sure that folks, to John's point, that really can see some valuable, very, very valuable changes made in their own life based on in lieu of services, which are those things that we can pay for, that we all have paid for in the past, but never got reimbursed for, but that the state's actually helping us to create that reimbursement schedule now. So there is some exciting pieces of that, but there is no question that the integration that's going to take now for all of us together as a team is going to be a uniquely different paradigm shift. It is exactly what Richard shared, the disparity of information between the siloed systems, and even where do you draw the line for somebody in the health plan that may have a moderate behavioral health issue versus a severe behavioral health issue, and who actually technically owns the care of that patient right now is different because each county and health plan kind of looks at those things differently, and the information flow that happens with those partners is not nearly as easy as you would think. And so the people resources that you have to place around that, in our case, we do constant huddles with our county partners to make sure there is some information flow along with some of the data flow behind the scenes is tremendous. And so I think it's a huge opportunity for us on CalAIM. It's a great question, but boy, we've got a lot of work to do to make it right.
Jarrod, you hit the nail on the head, I think, in what all of you are experiencing. John, you now have an opportunity to ask your colleagues, even though you guys do talk to each other all the time, but for public consumption, a question that you have of them that they can further explain what they're doing in their organizations.
Well, Richard earlier talked about a survey he did where food insecurity was the #2 issue. We certainly see that here in Los Angeles, and immediately after the pandemic started and the recession started, the County Department of Public Social Services told us that the applications for CalFresh or food stamps went up 200%. So we started doing, so what we did in LA, and I want to ask each of you if you did something similar in your counties, we used those community resource centers to put on food banks. In other words, we partnered with some agency that had access to food. Then we provided the location, the manpower, the publicity, all of the logistics to do it. We did about 30 last year. We've started them and we're doing them still. And we'll get like enough food for 400 families, and boom, it's gone in 2 hours and there's still a line. So obviously our members are in great need. What are you guys doing locally to help address that, if anything?
I'll go ahead, Jarrod.
Go ahead, Richard. Well, no, I was just going to share that, you know, this is an interesting topic because I remember when John and Baackes and I were talking about this very early on and learning together about that need in the communities that we serve. This goes exactly back to a comment that I believe John made, or Richard may have made it, that it's interesting to me the massive need that was there, huge need. I've not even ever seen anything like that with the number of different food distribution centers that we set up with partners all across the Inland Empire. But to John and Richard's point previously, if you're giving to your member that has diabetes frozen pepperoni pizzas, because that's what you're getting through the distribution chain, that's what you can get from food vendors and food distributors. That's great that they're getting food, but we're not taking it to the next step to actually do the kind of work that we are designed to do, which is to make sure that things like the medically tailored meals that my colleagues talked about are absolutely connected to the member in a way that can actually change their life, both in the health outcomes, their current health issue, and of course, for the quality of care that they'll receive in the future. And so a lot of great work had taken place, I think, at all of our plans. But to my colleague's point before, we've got to get to the next level. And that's what I'm excited about, that actually CalAIM helps to empower us to do.
And Sajid, I will say it's interesting because Jarrod mentioned that he and I had a meeting with our teams recently, and this was one of the topics because at CalOptima, to John's point, similar story, SSA, our social services agency, food stamps skyrocketed during the pandemic. Not so much Medi-Cal. We did see an increase in Medi-Cal signups, but for food services, unbelievably impacting our food banks and our food providers. And they're telling me they, like John said, all of them open up for first thing in the morning within an hour. And you see the lines at every one of them. They're out of food. And frequently, as Jarrod pointed out, canned goods, packaged goods, pastas, maybe not necessarily the foods we'd want to see for our specific populations, because we're seeing our diabetic costs just reaching unprecedented levels. People are isolating at home, they're not eating healthy, and for diabetics, it's having a very negative impact. I talked to Jarrod about an idea we had related to delivery of healthy foods to diabetics in particular. He went before me and has tried similar things and he was quite honest, and Jarrod, I don't want to say anything out of turn here, with mixed results, but what I'm hoping is that we can learn from each other, linking them with food, CSAs and farmers markets and other things that we can do, because we're seeing devastating health impacts to our diabetics because of diet mainly. And if we can just eat, we're starting small and hopefully going to work with that population to see if we can actually make it work. Because as probably experiencing in Riverside and the Inland Empire in LA, we have areas of Orange County where if you try to find a lettuce head, a fresh lettuce head, and ripe tomatoes, all you got is 7-Elevens and other fast food type facilities near you, and that's it. And you don't have a car, so you walk. So that's all you got. So we got to do something about that. And again, maybe taking a small chunk is the approach we're taking.
Well, Jarrod, you want to just chime in I think you want to just chime in a little bit if you want to on that note, and then we'll move to the next topic.
No, I'm good, Sajid. I just think my colleagues hit the nail on the head. So absolutely perfect.
Awesome. Look, gentlemen, I have to tell you, time is flying by super fast, and we've got about 8 or so minutes left, and of course we could probably talk for another hour. There are a couple of questions remaining from the audience that were asked, and I have one in particular. So in these last few minutes, think about an answer to this question. If one of you answers it, I'll consider it answered by the group. But also, if there's any one last comment you want to make to the audience, that would be great. So the first question is a quick and easy one, I think. What are payers doing to work closely with emerging tech companies to help innovate? As you know, HIMSS is a technology society, a healthcare information technology membership. So I think that question is about, what are these big public organizations that you guys manage doing to support emerging tech companies to solve some of these problems?
I'll quickly answer.
Go for it, John.
We're trying to sort out which one of you know what you're doing. We are, I mean, frankly, we're overwhelmed with solicitations from newly minted technology companies that have some private equity money. And it's great. But frankly, we're inundated, and trying to sort out what's the best approach is our job at the moment.
Yeah, I think I'll leave it there, unless Richard, you've got something to add. But I just want to highlight that right before the pandemic, Inland Empire Health Plan, which I've been working closely with recently, and I got to do your CalOptima's virtual care plan as well. But right before the pandemic, IEHP was launching a physical innovation center, and that got put on hold with the pandemic. So I think each of the organizations, to answer the audience question, is John's absolutely right. There's an inundation of new ideas and new companies hitting Medicaid and public organizations like these payers. Let me move to the second question, which also may just have a quick answer. And it's something that I'm interested in as well. The question is, what is being done to support new reimbursement codes to support healthcare organizations adopting technologies that will help bridge the gap in care delivery? I think specifically the telehealth codes and the waivers and what's going to happen next. Richard or Jarrod, you guys have a thought, just to give you a chance to chime in?
Jarrod, I don't see Jarrod jumping in. I would say that first things first, I would say is I hope this isn't kind of a response and pull back because just like telework is here to stay, and that's a whole different topic unto itself internally. I think telehealth is also here to stay, and we need to take advantage of it. So first things first, let's make sure it becomes a standard reimbursement the way it's being done now. And so in terms of that next step of what are we doing with technology, I got to say, the tech folks are aware of what's going on and aware of this space to be filled. So like John mentioned earlier, getting a lot of input, maybe a little inundated with it. So let's sort it out, and maybe I can learn from John or Jarrod of anybody that they've seen that's good in this space, or maybe at the state level even, that we could maybe rely on.
So Jarrod, you're in DC. What can you do to make these codes stick? Come on, man.
Well, I wish we could do more. You know, it's interesting though, because I do think that because of the pandemic, I think it does give us more traction to share some of the incredible stories of both the triumph that have taken place in our organizations, as well as opportunities that we could be doing better. And you have to remember, you know, this season that we're in has been interesting on the technology side, because at least for our organization, in a matter of about 2.5 weeks, we had 2,400 employees working from home very quickly. Now, that could not have happened in our organization or any of our sister plans overnight without incredible technology leaps and bounds that our team took. I would really encourage folks that are on the call to really take a minute to look at the CalAIM information that's on the state site. Take a look at the executive summary if you don't want to read all 200 and some odd pages of the full thing, and find out, to John's point, you know, what do you think you can help us solve that's in there, particularly around the member quality piece and engagement piece, and how can we really make a difference in the communities that we serve. And I know there's some great technology that's happening out there. And to Sajid's point, we do have our innovation center that's complete now. It's finished. It's ready to open the doors when we get the green light from public health to do that. And I can't wait to have more conversations with folks about how we can actually help to meet the needs of our most vulnerable populations that we serve.
Awesome. So, gentlemen, with just a couple of minutes left, allow me to make just a comment and maybe sneak in one question if there's time. First of all, I want to say thank you to all three of you. You know, you guys have been leading your teams and your organizations in serving the population that if an LA Care, a CalOptima, and an Inland Empire Health Plan did not exist, I think the challenges in Southern California to support these populations would have been tremendously greater. So as public agencies, not just providing healthcare coverage, but I think as Jarrod, Richard, and John mentioned, you guys have been paying for food and travel and other services, mental health and other services that as plans you guys don't get to really showcase. And many in the state of California or even outside of the state don't understand the service that you guys provide. And just to give you guys context, 5 million members of the three organizations that are served by these three organizations is the total population of the state of Arizona, and greater than about 20 other states in the union. So that's perspective. Let me end this thought with both a comment and 2 comments. One, I've had the pleasure personally of working with each of you and each of your organizations. I started out at LA Care and got to do a lot of innovation, and in particular, e-consult, launching e-consult throughout LA County. Inland Empire Health Plan, Jarrod and previously Dr. Gilbert supported and launched eConsult throughout the 2 counties there. And I know, Richard, you and your organization's looking to launch eConsult later this year. So having said that, though, the key issue is still inequity in access to care. So I want to leave this thought because of time with the quote that I put in the background. I forgot to mention it at the beginning, but I think MLK, Martin Luther King Jr. said it perfectly. Of all the forms of inequality, injustice in healthcare is the most shocking, inhumane, and that was made over 50 years ago. And so I think that the challenges you guys all discussed is so important. I hope actually that we're able to get the 3 of you again together in 6 or 12 months and talk about where you guys have landed in progress, and hopefully in a near post-pandemic environment. So I think with time up, because I'm getting the notice here, John, thank you. Jarrod, thank you from calling in from DC, and Richard, thank you. Any last comments from either of you?
Jarrod, pick up some fresh 20s, will you, from the mint?
That's for you, Jarrod.
I'll do my best. I'll do my best for you, John. Thanks, Sajid, for having us. This is so good to connect in with you folks. And thanks for the work that all of you folks do to help the connection happen even more meaningful for our members and providers too.
Richard.
And I just want to express my thanks, like Jarrod, to you for putting this together. And we do talk to each other all the time, but this is a very good conversation to continue ongoing, of course.
Great. And John, thank you. I know that you guys in particular, you, John, in particular, made some time for this, considering things I can't mention. So just to make it public, what you guys are doing. So thank you. Sonny and my friends at SoCal HIMSS, I return it back to you then.
Thank you, Sajid. Thank you, Richard. Thank you, Jarrod.